turbo engine running.
Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
Advances.
Questions. Research.
technology.
Unbelievable.
Without further ado,
This is The Naked Scientists. Hello, welcome to The Naked Scientists, the show that brings you the biggest breakthroughs and also talks to the major movers and shakers in the worlds of science, technology and medicine. I'm Chris Smith, and today, the medical problem much more costly than cancer that is destined to get dramatically worse in the years ahead. If I told you that a big healthcare system like Britain's National Health Service, or NHS, spends much more money treating chronic wounds than it does on combating cancer, more likely than not you'd wonder if I needed to check my figures. But it is absolutely and shockingly true. Billions are ploughed into the problem, but the situation isn't improving. Most of these wounds lie downstream of disorders like diabetes, and the biggest risk factor for that is obesity. Alarmingly, official figures out last week show that, like many Western countries, nearly a third of the UK population is now in that weight category, and therefore the diabetic, and subsequently the wound problem, is destined to become much, much worse. The UK government recognises this risk and that this is a poorly understood and poorly managed part of healthcare. We're just throwing money at the problem without really fixing it. So what are they doing about it? Well, they've invested in a new Wound Innovation Institute based at the University of Hull in the northeast of England to bring together academics, clinicians and industrial partners to try to get under the skin of the wound care problem and harness science to develop new diagnostics and treatments. We're in partnership this week with UK Research and Innovation, who are supporting this new initiative, and Matt Hardman is the Wound Innovation Institute's director. We got talking about the scale of the problem he's up against and how he plans to tackle it.
It's a huge drain on worldwide healthcare. In the UK, the NHS spends about £8.3 billion per year, roughly, on wound care, which is almost the same as is spent on managing cancer or obesity.
Really? Why haven't I heard about this?
It's mainly, I think, because wounds are kind of a hidden problem. Most people don't publicise the fact they've got a persistent chronic wound. And they're also a major human burden. So people who have wounds have chronic pain. And because of that, they tend to socially isolate. The wounds can kind of produce a lot of exudate. They don't smell very good, lead to anxiety, depression. Ultimately, people who suffer from wounds have reduced independence.
So it's a multidisciplinary problem. It's not just a cut on your foot. The implications and the domino effects are quite profound.
Yeah, and I think people tend to think that, because when they're younger, they have a wound and it just heals, you kind of assume your body is going to be able to heal. But as you get older or you develop diabetes or you have vascular insufficiency, then that can lead to a position where you develop a wound and it actually can persist for many months or even years. And the worst part is if you have a wound that persists for that amount of time and goes on to develop infection, you can actually end up with having to have an amputation. And if you have your leg amputated, there's only a 30% chance you'll still be alive after 5 years.
Now, are we spending a lot of money on this because it's just a big problem, but we're pretty good at dealing with it? Or are we actually really not very good at dealing with it? And we're actually spending all that money on those repercussions and downstream effects that you've just outlined?
It's absolutely the latter. So the understanding of the fundamental biology of wounds is not as complete as other areas like cancer. Weirdly, there's a lot of commonality between wounds and cancer. A lot of the biological processes that occur during wound healing are actually hijacked during cancer, but that's a whole nother discussion. So I think that because there's not been a huge amount of investment in wound research, we don't have that fundamental understanding, and then the treatments that are available, some work reasonably well, but there are no kind of blockbuster treatments for wounds.
And is that what you're trying to change? You are unleashing a sort of step change up there in Hull.
Yeah, well, I've spent my entire career working on wounds and I've seen incremental changes. But yeah, at Hull, we are really pushing the boundaries of what's possible. And we've been able to do that through significant investment from the UK government, from the university, which we're very grateful for, and a consortia of partners that we work with, both the NHS of the UK and industry partners.
So, what's got the government interested to the extent? Because my understanding is they've invested about £16 million in your initiative, which you're then able to leverage more from industry through sort of partnerships and things. But what's made them do this? I mean, obviously you've made them do this, but what is it that's made them receptive?
Particularly in the region where we are in Hull, we have a very socially deprived population who have real problems in terms of wound healing. We have many people per week having their leg amputated due to persistent chronic wounds. And I think that it's the right time. A number of technologies are now coming in, like genomics and like omics technologies, that will allow us to have really important new insight into the causes of wound problems. And we have the infrastructure now that will really enable us to kind of start to address the different aspects of wounds that we couldn't address previously.
How are you going to spend the funding then? Are you spending this just on research projects, or are you effectively building the facility that will enable you to then explore all these different avenues going forward?
That's a great question. So the 16 million from the UK government was all for infrastructure and equipment. So we've just finished spending that. We've bought 12 million pounds of equipment and refurbished laboratories. The added value now is obviously that gives us fantastic infrastructure to then be able to push forward with research projects. And it's the partnerships that are really important for driving those research projects. The university have funded us with significant investment for people. And so we're having a big recruitment drive at the moment to bring in some world-leading experts to supplement the capabilities we have, recruiting at all different levels, to then allow us to be able to undertake more volume of research.
And what will be the big targets? Usually when you have an initiative like this, you draw up a list of your big hits, the things you're going to go for first. So what's at the top of your wish list?
So wounds is simple. You can kind of break it down into three areas. Prevention is better than treatment. And actually, the reason that a lot of people develop chronic wounds is that they don't do what they could potentially do to prevent those wounds. And that applies to the patients and also the healthcare professionals. You know, if you can see the patients more quickly, if you can look at things like telemedicine and remote diagnostics, if the patient awareness is increased in terms of how to look after their feet, look after areas of their body that could be susceptible to developing chronic wounds, that could be a game changer. Then there's infection. There's a lot we don't understand about the causes of wound infection, how the bacteria that inhabit your skin can lead to infection in certain situations. And then there's the treatment side. And in terms of treatment, there's a lot we're doing now in terms of new technologies, things like 3D bioprinting, and looking at ways to actively promote wound healing, which is something that paradoxically doesn't really happen in terms of current wound management. It tends to be kind of passive treatments, putting a dressing on to protect the wound rather than active treatments to promote healing.
Matt Hardman at the Wound Innovation Institute. We'll hear a bit more from Matt later on in the programme. First though, why are people with diabetes at such high risk of developing chronic, incapacitating and potentially lethal wounds, which frequently include foot and leg ulcers, as well as sometimes even infections spreading into underlying bones that can lead to amputation? And what can we do to change this? Ketan Dattaria is a professor of medicine at the University of East Anglia, and he's the chair of the Association of British Clinical Diabetologists.
There are three real things that really impact people with diabetes. And the first one is if your diabetes has not been very well controlled as it could have been over the many years, you get certain conditions that predispose people to developing ulcers. The first one is nerve disease. So the nerves that carry sensation in the feet become numb, so you can't feel your feet. You can end up getting a small wound, you cut your toenails too short, or you get a stone in your shoe, something you don't feel it. And also, people who have diabetes, the blood vessels in their feet become very narrow. So you can't expand the blood supply. If you wound yourself, if you cut yourself anywhere on your body, you normally you know how did that much blood come out of that little hole. But in people with diabetes, they can't mount that. So you've got the problem of a wound which you can't feel, blood supply that doesn't get there. And also in people whose blood sugars are quite high, then the infection fighting cells don't work very well. So you've got it's a perfect storm with diabetic foot problems.
Is there any evidence that the rate of wound repair, the rate at which cells grow to restore integrity of a skin layer, for example, is that compromised in people with diabetes?
Absolutely. So there are problems with diabetic foot wounds in that you've got acute wounds, those that occur quite quickly and they can heal very quickly within a few days or weeks. And you've got long-term wounds or chronic wounds, and the biology of chronic wounds is very different. And if you've got those ongoing problems of neuropathy, so nerve damage, poor blood supply, and actually also pressure, which stops the blood from getting down to that wound, then the wounds become chronic, and that makes a wound much more difficult to heal.
What have we done historically to try to address that? Obviously, better management of diabetes has got to be upstream of all of this. But for some people, they're already in this position. So we want to heal their wounds up. So how have we tried to do that, or how do we currently try and do that?
So there are only three ways really of trying to improve things. The first one is pressure relief, keeping the pressure off a wound to allow the blood to get down there and stop the shear stresses from continuing to break the wound down. It's improving the blood supply. So if you've got tight blood vessels, then maybe seeing a vascular surgeon may be necessary. And thirdly, it's just treating any infections in the wounds. There are other things like good podiatry care, so good what's called sharp debridement with a scalpel just taking off all the dead skin. But effectively, those are the only things that have really been proven to show improvement in wound healing in people with diabetes-related foot disease.
And in terms of future directions, what sort of avenues are people exploring now actively to try to optimise not just the prevention side of it, but also if people are in this position, making sure their wounds do recover more promptly and stay away?
So we're in the process of updating the guideline on wound management for the whole world. And there are only two interventions which have definitely been shown to help, but they've only got one trial each. So it's not great evidence. One is a special kind of dressing, which is available in most parts of the world, which has got a special substance in the dressing that helps people who've got poor blood supply and nerve damage. Those are the only people who have been shown to help the wound healing. And the other one is actually very interesting, where they take people's blood, they put it into a centrifuge, they spin it down very quickly, and the cells, the infection-fighting cells and the things that help wounds heal rise to the top. That's called a buffy coat. You take the buffy coat and you put that onto a wound. And again, that's been shown to help speed up wound healing. The problem is in the UK that it was not deemed to be cost effective by the people that tell us what to do. So NICE said it was not cost effective, so we don't use it regularly.
How does it work then, that technique? What's thought to be the mechanism of action?
Because it's got all the proteins, all the platelets, all of the good stuff that helps wounds heal are in that top coat. And you can take it off. You can spin it down so you're just left with the liquidy part of the blood, which you discard. But the top bit you can take off and apply it to a wound. And you have to apply it every couple of weeks until the wound heals. But it's got all the growth factors, it's got all the things that wound healing cells love to help the wound from healing. But as I said, it takes 25, 30 minutes to spin it down. And in a very busy foot clinic, most of us can't afford that time, so it's therefore not cost effective to do it.
But the efficacy is high then?
It is. It increases the chance of healing by about 50%, yeah.
Can we not short circuit this or find a better way? Because with that level of response, that sounds like an amazing intervention.
It would be, and we'd love to do it. And I think the teams who invented the process are trying to work on it so it makes it faster. But the trouble is, within the hard-pressed NHS environment, we have to think of the numbers of people coming through the door who we can treat, because it's not for everybody. You can't give it to everybody, it's just for a certain kind of foot ulcer as well. So that's the difficulty.
Even so, wouldn't it be good if we could do that more generally? And it is interventions like that that Matt Hardman and his colleagues at Hull's Wound Innovation Institute are actively pursuing and trying to harness better. That was Ketan Dataria, Chair of the Association of British Clinical Diabetologists.
The Naked Scientists podcast is produced in association with Spitfire, cost-effective voice, internet and IP engineering services for UK businesses. Find out how Spitfire can empower your company at spitfire.co.uk.
You're listening to the Naked Scientist podcast with me, Chris Smith. Today, the health and economic impacts of chronic wounds are going under our microscope. Shortly, we'll hear more about the new avenues that scientists are exploring to try to forge new inroads into an underappreciated problem that is more costly than cancer. But first, we need to look a bit more deeply into the mechanics of what's actually going wrong in a chronic wound to frustrate the healing process. And it turns out that it's a perfect storm of entrenched infection, with microbes lurking beneath protective chemical shields we dub biofilms, alongside overzealous but dysfunctional immune responses, a compromised blood supply that limits the delivery of immune cells and raw materials needed for repair, and an inflammatory milieu caused by damaged senescent cells. That's the problem. Now, some or all of these factors are usually playing a part, and the person who's been unpicking all of this to work out how best we can intervene is the University of Hull's Holly Wilkinson.
So we'll look inside a diabetic foot ulcer. These are obviously a type of non-healing wound. They're characterised by a lot of infection, and also lots of different types of microbes reside in those types of wounds. We will also see that a lot of those microbes are encapsulated in a type of slime, which we tend to call biofilm. And this actually protects those bacteria from our host cells, which might want to fight those bacteria. And it also protects those bacterial cells from antibiotics as well. So one of the reasons that we end up with really problematic infections in these wounds is because of this slime that encapsulates these bacteria. In those wounds as well, we also see lots of different types of skin cells. And in this environment, it is very inflammatory. So we'll have lots of types of immune cells that are in there, both trying to attack the bacteria that's in those wounds, but also just behaving in the wrong way.
When we look inside this sort of wound, the skin has got multiple layers to it. So how many layers has this wound gone through? And what effectively happens at the bottom of the wound, like the bottom of the well? What is there? What's it hitting? And what is the body doing about it?
Yeah, so these wounds do go quite deep. So we go through the layer that we count as the barrier of our skin, which is our epidermis. And we go into the tissue that is underneath that, which is our dermis, the part of our skin that is full of collagen, and it gives our skin that kind of youthful structure. And when you have a wound that fails to heal, you get breakdown of all of that collagen. So we eat away at that nice structure, and it can go quite deep down to kind of the underlying fascia, the underlying muscle, the underlying bone, when these wounds become very, very serious.
The body must sense that somehow. So how does the body know that that breach is there?
So what tends to happen as kind of a first line response is the cells that we have in that barrier layer, they release signals if they become injured. So they release damage associated signals. And also we have bacteria on the top of our skin, and our skin cells sense those bacteria, and usually they exist together in harmony, they communicate with each other. But if you get a breach to the barrier, that can throw all of the signals off as well. So we then also get bacteria associated signals that shouldn't be there. And that also signals to the body that there's a problem here that we need to solve.
And what's the body's response? These signals come flooding out of the wound. There's presumably a gradient. They're hottest where the wound is, and the signal dissipates away from the wound. So how does the body use that, and what's its reaction?
Yes, so there's a few different things that happen all together. It's kind of an orchestrated, if you like, a concert of kind of different instruments that all come together to produce this wound healing response. So we have activation of the immune system. So we have kind of sentinel cells that guard the epidermis that are immune cells, and they get those signals, and then they leave the epidermis and they migrate out of the skin to go and tell the body that we need to mount an immune response to this. So then all of the new immune cells flood in from the blood. We also have the cells that are in that top layer of the barrier. They also become activated, and usually they're kind of like a brick and mortar structure, and they kind of just sit there solid in their little shape. But when they get activated by these signals, they kind of shimmy away from each other and become less of a brick and mortar shape and more like loose cells that can move around. And then obviously when they become like that, they can then start migrating and moving to close the gap that has been created. So there's lots of these different activation states that happen to our cells that changes them from how they function in a skin environment versus how they function when we have an active wound.
How would it heal normally? So say this is not someone who's destined to get a chronic wound. It's just a cut. You slip with a knife and you breach your skin. Presumably all the mechanisms you've just outlined, they're invoked, but you don't end up with a chronic problem. So how would it work to heal up normally? Because if we understand what
Yes.
normal looks like, it's easier to see what abnormal looks like.
Yes, so normal wound healing happens in 3 to 4 stages. The first thing that happens is that immune response. So our immune system comes in, clears out any potential bacteria that could be a problem. And then this stage is then replaced by a proliferative stage where our cells that form the barrier will start to migrate to close the gap. And then if there is any issues lower down in the tissue as well, in the dermis, where we have all the collagen producing cells can start to produce more collagen and fill in all those gaps as well. And then we end with a remodeling stage, because we have to remodel all of the collagen that is put down initially, that is, quick and dirty, just put it all down to fill the gap. But then we need to make it into a proper skin structure. You can tell what the remodeling stage is if you looked at a cut on your finger, because you'll have scar tissue. And that's part of the remodeling of the skin, is the generation of that scar tissue.
So the first thing is that the immune system defends you. Meanwhile, the skin that's surviving at the margins knows we've got a breach here. The cells grow like bilio to flood in from the edges to fill the gap, as well as other cells making collagen to basically fill up and occupy the space. This all stitches itself together, but it looks ugly. And then a period of remodeling kicks in once we close things up to tidy stuff up and make it neat again. So why doesn't that happen then? Normally, in a person who's destined to get a chronic wound, a diabetic, why does that go wrong?
So there are multiple things that go wrong in somebody that has diabetes. So they tend to develop vascular problems, so their blood vessels don't work as well as they should do, and that affects blood supply to the skin, which then affects how well the skin cells function, because blood carries the nutrients that our cells need. And then also the underlying pathology of diabetes causes our immune cells to not function properly. We have a lot of underlying inflammation in the body. So when there is a wound, there becomes a situation where there's too many of these immune cells appear. And obviously we want a small amount of inflammation at the beginning of wound healing, because that's really important for clearing out any debris, allowing our cells to migrate, and also to clear out any potential bacteria. But if we have too many immune cells there and they're too activated, then they're basically fighting with our other cells in that environment. So they're producing factors that will degrade collagen, as our collagen producing cells are trying to put down collagen. So they're just constantly fighting with each other. And then it means that we can't properly fill in the gap.
Does the fact that they may have very high glucose levels, does that also affect the environment of the wound, so that any microbes that are there are basically being fed an all-you-can-eat buffet?
Yes, so high glucose does actually drive inflammation. So we know in terms of the pathways that are activated that glucose is a driver of those inflammation-related pathways. And one area that I'm actually very interested in and work on is a process called cellular senescence, which is an aging mechanism in the body. And this is actually driven by glucose as well. So if we have high glucose in the environment, it triggers our cells to become very, very stressed. And when they become stressed, they can go into what we like to call as a zombie-like state when they become senescent. And when this happens, rather than dying due to the stress, which is usually what happens with normal cells, they go into this zombie-like state where they don't die, but they're not alive and they're not functioning well. But they then produce lots of factors that drive inflammation. So we are also carrying out a lot of work in our lab to look at these zombie cells in diabetic wounds and kind of how they're preventing wounds from healing as well.
Holly Wilkinson at the University of Hull. So the aim here is to bring together all this learning to try to develop new approaches to wound management and healing. And that begins with better diagnostics, so you know what you're up against. Matt Hardman again.
So I think the first thing is it's really important to understand what the cause of the pathology is in specific wounds, because the treatments won't be the same for every wound. And I think it's understanding how to manage the different causes of that pathological healing is fundamental. So being able to develop diagnostics that can be used to kind of identify what treatment would benefit what specific wound is essential. So a good example is infection. So you can have wounds that are infected with antimicrobial resistant organisms and have biofilms that absolutely need to be eradicated and managed. But then you can also have wounds that have a very high level of microbial burden, but those could actually be beneficial microbes. And you don't want to be going in and killing those microbes because they could actually be having a beneficial effect on healing. So it's understanding the causes of the pathology to then be able to target specific treatments. And so with wounds, you tend to have devices. Almost everything is device-led, and that could be an antimicrobial dressing. It could be a negative pressure application to remove exudate and stimulate cells. But there are all kinds of other emerging technologies that are proving to be quite interesting.
I remember about 20 years ago interviewing a gentleman who was sticking electrodes in wounds, and he had one in the bottom and one at the edge. And he was able to show there was a voltage being created between the bottom of a wound and the sides. And he said that is the guide to cells that are proliferating at the edges and migrating in to fill the hole. Is that true?
Yeah, absolutely. There's a good amount of literature on electrical currents and electrical stimulation within wounds. There's been a number of kind of devices developed to address that. So there's dressings that intrinsically have electrical current within them. There are devices to apply electrical stimulation to wounds. One of the challenges is understanding that biology doesn't necessarily then translate into clinical efficacy. These devices have kind of relatively limited benefit in terms of the clinic. That is a problem because wounds are very, very difficult to heal. And so a lot of the technologies that are developed, you don't really know if they're going to work until you get them into people. The models that we have to be able to evaluate clinical efficacy are relatively challenging.
Does it matter where on the body the wounds are? Because skin, although we use the word skin, it's going to differ across your body surface. So presumably there are going to be some places that might be tougher to fix than others.
Absolutely. And again, this isn't something that's really not that well understood. The microbiome, the bacteria that inhabit your skin, is wildly different depending on what body region you look at. Your elbow and my elbow are more similar than my elbow and my head, which is crazy in terms of the composition of the bacteria that are there. We know that cells are fundamentally different depending on which region of the body you look at. And we know that the skin structure is very different. Particularly, a lot of diabetic foot ulcers form on the bottom of the foot. And your palmar plantar skin on your feet and hands is very different to the rest of the skin on your body. For example, it lacks hair follicles, and we know that hair follicles have stem cells, and those stem cells contribute to wound healing.
Presumably, also the immune response is going to differ across the body surface, because we know there are some places where the immune system is really tooled up and is on high alert all the time. I'm thinking of things like your genital tract, your gastrointestinal tract, etc. There are going to be other places where it's perhaps a bit more sluggish.
Yeah, yes, but I think probably the changes in the immune response are more due to changes with diabetes or age. We know that immune senescence is a big problem in terms of susceptibility to injury, and age is one of the main risk factors for developing poor wound healing. Generally younger people heal very well, and then as you get to a certain age, you kind of get to a tipping point, and then as you get older, your skin changes significantly and becomes much more fragile, thinner, and again that contributes to the susceptibility to injury.
So you have less agile stem cells in the skin because it's older, which is going to contribute. You've got a less agile immune system because it's older, and that's going to contribute. You've also got perhaps a less agile nervous system, so you can't feel when you're bashing yourself about. It seems like a perfect storm. You can't just solve one problem.
Yeah, absolutely. But then the really interesting question is, why doesn't everyone develop chronic wounds? It's probably globally around 1 in 4 people with diabetes will have a chronic wound at some time in their lifetime, and about 1 in 20 older people. So not everyone develops chronic wounds. Again, it's understanding what the different factors are that make people more susceptible to poor healing.
So what do you think then is the best way forward? As part of the new initiative, you're obviously starting and testing various things. How do you bring it all together to try to bring that cost that you outlined at the top of this program down as that enormous spend?
Yeah, it sounds simple, doesn't it? But the first thing is you absolutely need to do research that's informed by understanding the clinical problem, talking to patients, talking to clinicians, really understanding whether what you're doing in a research laboratory, whether you're a biomedical scientist or an engineer, has clinical legs and application. The second thing is it's really kind of embracing the technologies that are available. We have now the ability to sequence whole microbiomes in a very cost-effective way, whole genome sequence microorganisms in a very cost-effective way now, which opens up whole new opportunities to be able to have a really detailed understanding of what's there in a wound in terms of the bacteria and the microbes, to then be able to really target antimicrobials, anti-infection, anti-biofilm technologies where you need them, when you need them. And then on the host side, in terms of the host cells, there's a lot of opportunities to develop new treatments around the body of evidence that's already there. We are looking at hormone modulation. We know that hormones change significantly over the lifetime, and we know that changes like going through the menopause, reduction in estrogen has a significant impact on your ability to heal. We are developing new biomaterials that are able to then stimulate cell biology to promote wound healing. We've got new approaches in terms of taking new technologies to target things like proteases in the wound, which are essentially important for wound healing, but if you have too many, can digest wound tissue. And we're using things like cold plasma to be able to stimulate wounds as well as manage the infection. So there's a huge amount of opportunity there. The other thing that we're doing within the Institute, which I think can't be underestimated, is working on predictive modeling and predictive models, because you can have a really good idea in the laboratory. You can do the study from 20 years ago to measure that change in electrical current across a wound, but then you need to have the right kind of models to be able to test whatever you're developing before you put them into people.
Matt Hardman at the Wound Innovation Institute. Well, let's hope that their endeavours quickly begin to bear fruit and we see meaningful and tractable, tangible progress in the treatment of what is effectively a huge clinical iceberg towards which we and many populations like ours are steaming at breakneck speed. Today's show was brought to you in partnership with UK Research and Innovation. Now, we're back with the latest science news stories from the week on Friday, including everything you need to know about a new mRNA-based flu vaccine, which has just been approved for use in the United States. Hear how it works on Friday. And for more naked science in the interim, there is, of course, our science Q&A show that comes out every week. That's called Ask the Naked Scientists, and it's available on all good podcasting platforms. And there's also our space science strand, Naked Astronomy, for those who are very fond of heavenly bodies. Of course, if you appreciate what we do here and you'd like to get behind us and support the show, do please consider making a donation. You can do that at nakedscientist.com/donate. I'm Chris Smith. Thanks for listening, and until next time, goodbye.